doing. So after treatment is diagnosis, that's the next best thing we do as doctors. First we diagnose people, and then after we diagnose them, we treat them. So that's why we talk about those two as two main topics in EDM. So in terms of, this is really what we'll be able to speak about. For those of you who I would have taught this to an undergrad, right? I know it have familiar faces, so I mentioned this to an undergrad. If you remember it or not, what we're talking about is these measures, sensitivity, specificity, these kind of things, right? So that's what we're talking about really. Is some of the big things they'll be able to understand. So when we make a diagnosis as a physician, we're really playing a guess game. If I ask you, who's the last patient you see and diagnose? Tell me, anybody. The last patient you see or talked about and you diagnose, what you diagnose them? Anything? Anybody? Virus. I like that one, virus. So Christine, so tell me when you say virus, I mean, how sure were you the patient had the virus? Pretty sure? How sure? Give me a number. 95% confidence. I wonder where you get 95% confidence from. So, anybody else? Anyone else saw any other condition? You had some doubt as to what the person might have, but you're kind of thinking, well, it might be this. A PE. All right, so the PE, what the patient present with? Shortness of breath, chest pain, and at what point in time you started thinking this could be a PE? Clear. So no cramps, right? No signs of heart failure, normal lung exam. You did anything else? You had a ECG, sinus tachy, right? ECG, which is what the most common thing you'll see. What else? You did anything else? X-ray? It's not an X-ray? X-ray was normal. And after all of that then, if I were to ask you, how sure are you this patient have a PE, what you would say? Give me a number. 20%. Say 20% sure. Now, would you treat a person for a PE if he was 20% sure they had the condition? Probably not. So then what we would do, we would probably want to do more tests or do something else to try and figure out if the person has it. So when we all make diagnoses, it's kind of to a certain extent an educated guessing game. It's really the probability of a diagnosis. How much times, again, chest pain people, query ACS, right? How much times is right there? Everybody who goes into casualty is probably query ACS with acute chest pain, right? The query ACS means we're not sure. About 30% of patients presented with acute chest pain in emergency would turn out to have probably a cardiac pathology, probably, roughly, about 20 to 50%, but not everybody have a ACS. Question mark. So when we try to diagnose people, really what we think is the probability of a diagnosis. So usually there is really what we call a testing threshold. Now, if I tell you a 23-year-old guy come and he complained of chest pain right here on his chest, and he said it was a sticking pain right here on the spot, and every time he breathed in, it hurt, and when he breathed out, it was okay, and he had it for 2-3 days, he otherwise well and healthy, have no risk factors for heart disease. Right? Would you all test this person for ACS? 23-year-old. Would you do an ECG on this person? You'll do an ECG on this person. Good, fair enough. Would you do troponins on this person? All right, okay, fair enough. You can tell the emergency people, right? You can tell the emergency people. It could be pericarditis. That's right. It could be other conditions. That's right. So the decision to test a person for a condition, if the person's probability of having a certain condition is beyond the testing threshold, then we go ahead and we need to test them. If the person's chance of having a particular condition is below the testing threshold, whatever the condition is, and testing, then you'll say, well, probably this person don't have this condition. I am going to test the person for it. Similarly, there's always a treatment threshold. So if I ask just now if you're 20% sure this person have a PA, you say, yeah, would you treat that person for a PA? You probably want to be, how sure you want to be before you give a person PE treatment or institute the treatment for PE? How sure you must be? At least greater than 50%, okay. I thought you would have said 99, man. I thought you would say 99. So for most diseases too, there also exists a treatment threshold, the value beyond which we would say, well, I'm convinced this person has the disease. I don't have to do any more testing on them. I'm going ahead and I'm going to give them the treatment. But if a person in this blurry range, if they're between the testing and the treatment threshold, like possibly a patient we are 20% sure having a pulmonary embolism, then this is where you're going to test the patient. So I usually give this little description and intro because the definition of a test is anything that changes the probability of a diagnosis. That's the definition really of a test. So when we talk about testing in medicine, that's really what we do. It's anything that could change the probability of a diagnosis, both increase or decrease. Because in medicine, we're interested in ruling in conditions, and we're also interested in ruling out conditions. We want to know that person have this, what to treat them for. And before we send a person home from casualty, we want to exclude that they have life-threatening things before we say discharge, go home. So a test is anything that changes the probability of a diagnosis. So if we have to develop PICO, remember PICO is, we've been seeing it every week. PICO is the first step in evidence-based medicine and practicing. PICO for diagnostic study looks like this. In a 24-year-old prima gravida, how accurately does fundal height compared to ultrasound predict fetal age? And we can ask variations of this question. In an adult presenting with shortness of breath and chest pain, how accurately does a ECG or a chest X-ray compared to what's the gold standard to be? CTPA predict the outcome, diagnosing the patient with a PE. Right? So this is what a diagnostic PICO looks like. The I is some test that you're looking at. The comparison is the gold standard, what you want to compare it to. So it means when you're thinking about diagnostic PICOs, you should know or kind of have an idea based on what the patient presenting with. You should know what's the gold standard way to diagnose the condition. And ask yourself, am I doing the gold standard test? Today we heard about kidney stones. Gold standard for kidney stones is what? CTKUB, that's right, 100% accurate. If you're doing an ultrasound, if a person have you think a person have a kidney stone, you could do the ultrasound, but just keep in mind, an ultrasound is not gold standard. Probably 80% accurate, maybe you can miss some stones depending on the size and the location. So this is what a diagnostic PICO looks like. And the type of study that answers this question is what we call diagnostic studies or validation studies. So a diagnostic study would take a group of people who prima gravida, and then it will take that group of people, measure everybody fundal height, and then everybody do an ultrasound on everybody and compare the fundal height measurement with the ultrasound to see how it measures up against the gold standard. That is simply put what a diagnostic study tries to do. The reason we're able to use certain tests in our practice to figure out if a person have a disease or don't have a disease is because at some point in time, someone did a diagnostic study. And the test was hopefully accurate enough for us to use the test. But there are two ways we could use a test, and you'll see those ways in the book. There's some other diagnostic PICOs that just show up out of interest. I mean, a hospital exploring a diagnostic test options for H1N1. Is the rapid antigen test as accurate as a gold standard PCR? So we use rapid kits a lot, right? Both in general practice and emergency, use them. Does it give the same information? Will it be as accurate as the gold standard? Is it possible to exclude a diagnosis of MI within 6 hours of admission to the emergency department? What you ER people say? Within 6 hours. Right? So it depends. Can the V-scan in the hands of a trained ED replace traditional bedside ultrasonography?
Yes.
What you'll say? Yes.
That's
yes. A trained ED, trained person. You know? These are just questions I put up. And people have tried to answer these questions by doing diagnostic studies. Right? They have tried to answer these questions. So my question to you is, why not just do the gold standard all the time? Why are we looking for another test? Why not just do a CTP and everybody acute chest pain? Acute chest pain and short pain. Why not? Cost, expensive. What else? Availability is not available. What else? Exposure to radiation. It could have side effects, or it could be invasive. Any other reasons? If they have renal impairment, they can't get them contrast, they can't do certain tests, right? So it have reasons why we cannot do the gold standard test for the reasons you all see, right? Sometimes we can't do the gold standard because the gold standard is post-mortem. We can't kill the patient just to know what's wrong with them. What conditions the gold standard is post-mortem? You think any? Lewy body, right? So neurodegenerative conditions, rabies, Alzheimer's disease. You could only know 100% sure from postmortem study. So again, I can't just do a brain biopsy or kill the person just to know what wrong. So sometimes the gold standard test is invasive. Suppose you're talking about acute appendicitis. What is the gold standard for acute appendicitis? Gold standard. Yes, what you'll say?
A diagnostic lab.
A diagnostic lab. That's right. That's how we know. You have to get tissue tested. That's how we know. We can't take out everybody appendix who present with belly pain just to see they have appendicitis. So sometimes doing a diagnostic study, you have to consider these factors, and we'll see how they could design the study to figure it out. So this just to show, first step is asking an answerable question. Second step in DDM is to find an appropriate paper. Of course, I robbing you all of that opportunity because I've given you all the papers to appraise, right? So when I was looking for the papers for you all to appraise, this is what I would have done, right? I've spent the last couple of weeks just looking for possible papers to give people to present, you know? The ones that we'll be looking at next week, a little bit more interesting than the systematic views we looked at today in terms of relevance to your practice and, you know, the persons in the room being from ER. But when you do a search for diagnostic studies, just know that, again, how to do a search. Clinical queries have things arranged by etiology, diagnosis, therapy, and prognosis. So we looked at therapy, and of course, we look at etiology and prognosis next week and the following week. So what we do when we appraise a diagnostic study, so we kind of looking at how we do the appraisal from rather than how the study is done in itself, because it do kind of related. We ask these questions. These questions seem familiar. Are the results valid? What were the results? Can we apply it to our patient? Those are the three main questions all appraisals ask. Those are the three main questions that we'll address today, as well as the RCT appraisals that went last week. So when you do a diagnostic study, this is what you do. You take a group of people using the chest pain and PE example. You take a group of people and who present in the emergency room. You exclude some of them based on some criteria. You include people probably who coming in complaining of acute chest pain and shortness of breath with a normal lung exam and a normal chest x-ray, let me see, right? And everybody now who enter your study is subject everybody to, let me just say, do the dimers. You want to see how accurate that is. And then after you do the dimers on everybody, then after everybody gets a gold standard, everybody gets a CTPA. And then they compare both results. That is really the design of a study. That is why we're able to use the dimers now, and we'll see how we use it to rule out these conditions when patients present. Note that blinding is also applicable in a diagnostic study. How do you think blinding is used? Blinding means somebody don't know something. Who don't know what? The person who doing the dimers doesn't know the result of the CTPA for the patient, and vice versa. The person doing the CTPA doesn't know the result of the dimers. So the most important way blinding is used in a diagnostic study or validation survey is the persons who interpreting the test doesn't know the result of the test of the other one. Right? And sometimes what they refer to the new test as, they refer to this as the index test. So that's the other way they refer to the new test, the index test. And sometimes they refer to the gold standard as the reference test, so the reference standard, right? Just words, they all mean the same thing. So the new test also is sometimes called index test, and the gold standard sometimes is called the reference standard. Right? Now, was there an independent blind comparison? We said what blind is, and the reference standard. Did the sample include appropriate spectrum of people? Now, this is important because if you want to test a test to see how well it does, you want to do it on the same spectrum of patients as they would normally present in your setting. You don't want to only include people who are really, really healthy and include people who are really, really sick. In other words, if I want to do a test to see if the dimer is accurate in diagnosing PE compared to CTPA, I wouldn't only want to pick as my patients, cancer patients who are really, really sick, people who are completely immobile, who lie down in a bed in ICU. I wouldn't want to pick the sickest of the sick people who are almost likely to have a PE. And I wouldn't want to pick normal, healthy people who are perfect and fine and have no symptoms. That would be an example of what we call spectrum bias. Spectrum bias, it'll come up later on, really means that when you do a diagnostic study, you shouldn't pick the extremes. As we say, we shouldn't pick the fittest of the fit and the sickest of the sick. Because then when you use a test now, you're asking a test to distinguish between black and white. And when they ask a test to distinguish between black and white, that would actually be kind of easy. In reality, in practice, the patients we see are not on the extremes only. It's not only people lying down in ICU, people are cancer patients. It's not only people who are perfectly healthy. It's people who are in between. So if you have to do a diagnostic study, you should test the same spectrum of patients as they would present in a natural setting. Right? So that's what this question is asking. So for the people who are doing appraisals next week, when they ask this question, you're looking to see what kind of patients they include in the study. The easiest way to do this is to actually just go to a real life clinical practice. So if you want to test if the dimer is as accurate as CTPA, just go in casualty in emergency room with people presenting with acute chest pain, and that is the people you're going to look at, right? You test it in a real life situation. Did the results of the test being evaluated influence the decision to perform the gold standard? Now keep in mind, this is what we're talking about here is research. So the person doing the study to see if it works. So what we say is if we're doing a study to see if a treatment as accurate as gold standard, let me just say you do the D-dimers first. You do the D-dimers and it come out negative for a particular patient with chest pain. Does that mean the patient does not need a CTPA? No. You still have to do a CTPA because the D-dimers could be a false negative, right? So in a diagnostic study, the test result of one should not influence the decision to do the other. Everybody should get both tests. Within the study, exactly. So I'm not talking about clinical practice, right? I'm not talking about clinical practice. What I'm talking about is the studies that tell us how to practice now. So in the study, if you're doing a validation or diagnostic study, everyone in this study should have gotten both tests. Now, it's interesting that you say you mean in the study, not in clinical practice, because what happened in clinical practice, if a person come in, the low risk, the D-dimer is negative, you might say, well, this person probably don't need an investigation, a gold standard. You probably go home, watch your symptoms. If you get worse, come back and tell us. Now, if you do a diagnostic study and you do the diagnostic study in that setting, then it could affect the results, because then all the people who negative by the index test not going to get the gold standard, and you don't know if the people who are negative by the index test are false negatives, right? So sometimes, because I just now tell you all, when you do a diagnostic study, you should do it in a real life setting. But if you're doing it for the purpose of research to know if it's accurate, then everybody should get the test. But that isn't always possible. It is not always possible when the diagnostic or the reference standard is invasive. If we had to figure out if, let me pick something simple. If leukocytosis is a white cell count, how accurate is leukocytosis and diagnosing acute appendicitis? Not very accurate. Fair enough. Let me just say that's the question we ask anyway. It would mean if you have a group of people coming in with right iliac fossa pain, everyone gets a CBC and everyone gets lateral lab. How practical is that? Not very practical. So if the gold standard is invasive and you're doing a diagnostic study, sometimes what they actually do is say, well, you know, let me apply the test. And if the test say have the disease, well, we'll give the test the benefit of the doubt. All we're trying to determine if the test is accurate. We'll give the test the benefit of the doubt and we say, all right, you have to go ahead and get the gold standard test. But if the test is negative and the gold standard is invasive, what we would do is say, here what? You don't have to go on and get this invasive standard. But what we could do is we could follow you up over time and see what happens. So maybe the person who presents with pain, if you're thinking they have appendicitis, maybe if you follow them up, if the initial test was negative and they say, doctor, still getting pain, the pain even worse, if the person gets more sick, then they might eventually go on to have diagnostic lab. So it's a little bit different when you're looking at a validation study and the gold standard is invasive, right? So, and there's a type of bias, actually called verification bias. Verification bias means that the person who had the initial test, if they were negative, they tend not to get the gold standard. And the people who had the test, the initial test, if it was positive, then they go on to get the gold standard. That type of bias is called verification bias, which we'll look at and come upon later. At least for the purpose of research, when people do the study, it's fair enough to say, all right, we're not going to subject the people who are negative to the test to the invasive standard, but those people who are negative, you should have some objective way of making sure that they were really disease-free, right? So, I mean, maybe the person gets not the gold standard, but they get something else. Maybe they do a CT scan on them, maybe they do an ultrasound, maybe they do a blood test, maybe they monitor them every day, you know? So that is really what is done in practice. So are the methods for performing the test described in sufficient detail to permit duplication? So if someone, you're reading a journal article and they say they use this new assay to diagnose something, you have to ask yourself, well, if I'm going to use that same thing in my practice, I have to know what test to order in the lab. I have to tell the lab what assay to do. They must use the same machine, same reagents, right? So it should be reproducible. What were the results? These are the results. And these are the results that we have to interpret for, is the main thing I want you all to get from this class. I have a few other things we do with these later on, but these 6 measures, sensitivity, specificity, positive, negative predictive values, and likelihood ratios, so positive and negative results is how we could look at how accurate a test is. All of you are familiar with these measures. You all see them, you read them, you use them. Is the interpretation is the most important bit. So when you do your diagnostic study, this is the table you'll draw. Let me just say you take 100 people with acute chest pain, you're thinking of PE, you subject everyone to the gold standard CTPA, you either had a positive CTPA for PE or a negative CTPA. And then you take everyone, you do a D-dimers on them, you either had a positive D-dimer or you had a negative D-dimer. This is the table that you're going to draw, right? Again, this is from a diagnostic study. It's not from clinical practice really, it's from a diagnostic study. So based on this, A is the true positives because A has the disease and the test is saying that you have the disease. So based on that thinking, what is B? B is a false positive. Most correct, because B is a person who the gold standard saying is negative, so B is really disease free, but the test is misclassifying you as being positive, so there's a false positive. C is false negative, because C is a person who's really diseased, but the test is saying that you're negative, so C is the false negatives, and D, of course, is the true negatives. So trick question, I'm telling you all before, for the exam it wouldn't be 1, but trick question now, which one of these cells that have 1, 2, 3, 4, 5, 6, 7, 8, 9, have 9 cells, which one of the 9 cells refers to everybody who are diseased? Everybody who have the disease. A and C, most correct, that's the correct answer. A plus C refers to everybody who have the disease, right? Because remember, C is a false negative. C has the disease. Remember, everybody here have the disease because the gold standard positive. Whereas everybody, B plus D is all the people who are disease-free, right? So B and D is everybody who are disease-free. So the first measure I want you all to get is sensitivity. Sensitivity is A over A plus C. Please put the A plus C in brackets. I'm supposed to change it as A over A plus C in brackets. And is the ability of a test to predict the presence of a disease. The other word for sensitivity is not on the slide, but you can note it and write it down, is the true positive rate. A over A plus C. Here, A, if you notice, we say A was the true positives. So A over A plus C is what we call the true positive rate, which is the same as sensitivity. So out of all the people who have the disease, how much are positive, right? By the test, right? Out of all the people who have the disease, how much are positive by the test? But the mnemonic is SNOUT. SNOUT, a highly sensitive test, is good at ruling out a disease. They might think, well, I now tell you sensitivity is the true positive rate, and it's A over A plus C. How you could use that to rule out disease? The reason is, when we look at sensitivity, the definition of sensitivity is in relation to the gold standard, right? A plus C is all the people who have the disease. So in a test that's very sensitive, if A over A plus C is sensitivity, if I tell you the sensitivity is 100%, what that says about A and C? It don't have any false negatives, most correct. So if you do a test that's 100% sensitive, C is 0. So when you come now and you do your test in clinical practice and your tests come out negative, you're sure that all the negative test results here refer to the true negatives. That's the reason why. So a test that's 100% sensitive has no false negatives. So when you get a negative test, not a negative gold standard, negative test, C plus D, you're sure all the negative test results refer to the true negatives. That's why sensitivity is good in ruling out the disease when sensitivity is high. Now you might ask, well, where's high sensitivity? Generally more than 80% is high, but as we'll see, it depends. How high is high depends. Some tests 80% sensitivity might not be good enough. You might want a test that's 95% sensitive or 99% sensitive. It all depends. So if I tell you D-dimers has a sensitivity at 90%, then for PE, that means what? It's good at ruling out the condition when, of course, the test is negative. So when the D-dimer is negative and the sensitivity is high, that means you can tell the person chances are you don't have a clot in your leg when you're long, whichever one you're looking at. Right? So you'll understand that sensitivity. A test, when you hear sensitivity, you're talking about ruling out the condition. If I tell you the sensitivity is 50%, which poor, and I ask you what the test good at doing, what you can say? You say it wasting time. Before you condemn it completely and say it wasting time, we have another measure to go to, specificity. But at least you could say a wasting time in terms of ruling out the disease. So if the sensitivity is 50%, you already know that this is a waste of time and ruling out the condition. Right? The example that I use here, just to put some numbers up, this is from a work that Prof. Maraj in our unit did. What they did is they looked at this thing called the Zong self-rating scale. The Zong self-rating scale is a scale that a person could fill and is a scale that you could use to try to figure out if a person has depression. There are many other rating scales that you use. There's PHQ-9. There are many other rating scales you could use for depression. And there's PHQ-2, 2 questions, PHQ-9, 9 questions. This one looked at this one called the Zong self-rating scale. So based on this was the test. And the gold standard to see if the patient had depression was a psychiatrist interviewing the patient, applying classic DSM-5 or 4 criteria, whatever, to see if the person meets the criteria. So this was the gold standard, the psychiatry interview. So based on this data here, will be the sensitivity. So this A, this B, this C, and D. Sensitivity is 60%, 6 over 10. Perfect, excellent. So all the people who had depression according to this study was 10 people. All these 10 persons had depression, all these 33 persons did not have depression. So the sensitivity was 60%. What do you think about that? Let's say sensitivity is good, you're thinking it good if it's more than 80, then you're probably saying 60, not all that. So you're already thinking if you have a negative Zong scale score, if you're negative, if you test negative, meaning whatever the criteria is for negativity or positivity, that's a different story. It means this is not really good at ruling out depression. Exactly, not too helpful. The other measure that we look at is called specificity. Specificity is D over B plus D. Please put the B plus D in brackets. Specificity is the ability of a test to determine the absence of disease. So going back to this graphic, B plus D is who? All the people with all the disease. And D is a D as in dog, D over B plus D. D is the true negatives. So D over B plus D, which is specificity, is also the same as the true negative rate. Right? The true negative rate. Don't mix up the true negative rate with the true negatives. The true negatives is D. Right? Here, the true positives is A. The true negative rate is D over B plus D. The proportion is a fraction. The true positive rate here is A over A plus C. Right? So specificity is out of all the people who don't have the disease, how many are negative by the test? So then based on that definition and the fact that it says the true negative rate, you might think, well, hey, that is about ruling out, but no, it's about ruling in. The mnemonic is spin. A highly specific test, spin, is good at ruling in the condition when the test is positive. So I just got a message from one of the year twos actually in class, and she's looking at a patient, and she's in Guyana now, and she did this test, the IGRA. You know the IGRA? IGRA is an interferon test for diagnosis of TB. It's an interferon-based test. It's a blood-based test as opposed to MAN2, right? And she said, well, this person IGRA came back positive. You know, what does this mean? So I asked her, well, in Guyana, I know some parts of the world, they give BCG vaccine. So she was like, yeah, everybody in Guyana gets BCG vaccine. So I was like, well, I don't know if a BCG vaccine will cause the IGRA to be positive. I know a BCG vaccine can make a MAN2 test positive. A BCG vaccine can make a false positive MAN2. So I'm going to look it up now, and UpToDate, best thing ever in the world. And UpToDate says, yes, UpToDate says the IGRA is not affected by previous BCG vaccination. And the IGRA test said that, and UpToDate said the IGRA test has 95% specificity for the diagnosis of TB, be it latent or active disease. So I told her, well, in this case, that means this person had either had TB or have TB the IGRA can't determine the difference between previous infection and current infection. So of course, the person is asymptomatic, he has a normal X-ray, or I think you're going to send him for an X-ray. So when we talk about specificity, you're thinking is about ruling in the condition. So what that means, if a test is 95% specific, it means if you're positive by the test, it means you almost certainly have the condition. And the reason for that, again, you could go back to this graphic. If a test is really, really specific, it means the false positives are low. B is almost 0. And if B is almost 0, when you do the test and you get a positive result, you show all the positive results, which is A plus B, refer to the true positives. That is why a highly specific test is good at ruling in the disease. Anybody confused so far? You following me? Once you follow me, then it's good. This is probably the hardest bit really to follow. Everything else you could work out after this. Right? So specificity is about ruling in the condition. So if I tell you now, D-dimers has a sensitivity of 95% for the diagnosis of DVT and specificity of 60%. What does that say about D-dimers? 95% sensitive, 60% specific for DVTs. Meaning it's only good at ruling out the disease. If you have a positive D-dimers, you still probably need to do follow-up testing to see if the person really have a clot. Right? How we use this in medicine, it depends on what your goal as a physician or a doctor is. If your goal is to rule in the condition, you want a test that is very specific. If your goal as a doctor is to rule out a condition, you want a test that is very sensitive. A&E people, highly sensitive troponin. Why they call it highly sensitive troponin? What I mean then? It's really to rule out. It means when you do your troponin in a query ACS patient and it's negative, it's very sensitive, meaning you could rule out that the person having ACS or MI and maybe send the person home or monitor them less or do something. So that's what we see, right? So it's how we use it. Now, sometimes we want to know that a person really have a condition. If the treatment is we have to do an invasive surgery, cut the person open, put them on a general anesthetic, risk complications, before you do that to someone, you want to probably really make sure the person have the disease. So you would want a test that is very specific. The ideal test in medicine, of course, is both very specific and very sensitive. But in reality, there's often a trade-off for one over the other. There's often a trade-off. The ideal test is very specific and very sensitive, but often in real-life practice, there's a trade-off. Some tests, though, are very sensitive and very specific. Like when I talk about this with undergrads, I tell them HIV testing is 99.9% sensitive and 99.9% specific. What does that mean? When you do a rapid HIV test, what I say? If you're positive, you have the disease. If you're negative, at least you don't have the antibodies. Maybe in the window period, we don't know, but you don't have antibodies that detectable. So when you do a test that is 99% specific, you can tell the person if it's HIV, chances are you have HIV infection. The chance of a false positive is almost non-existent. It's so low. Right? So the ideal test has both. So if we have to go back to this example, now one will call specificity. We said specificity is D over B plus D. So if you have to go in this example, D would be 31. D plus D is 33. So 31 over 33, worked out, whatever it is about, I think, 97%, maybe 94%, right? So that means this test is really, really specific. So that means if you're positive by the IM-Zong scale, yeah, send the patient by the psychiatrist. You could tell the patient, yeah, what? Yeah, depression. We probably should treat you. I just say, you mightn't do that in real life practice, but I just say. If it's negative, though, it means, well, it don't necessarily rule out depression. So you still probably have to probe and ask the person maybe some more questions or do some other tests. So that's how we'd use it in practice. Right, so you all got sensitivity and specificity. If you forget it and you was lost for the last 5 minutes, just remember, just memorize, spin and snout. Once you remember that, easy. But what I told you is how we could work it out. Once I could work it out and understand it, it all makes sense. The other measure we can look at is positive predictive value. Positive predictive value means out of all the people that is positive by the test, how many are truly positive. So note the denominator here, and again, please put it in brackets, right? That's supposed to. It's A plus B in brackets. So it's A over A plus B. Out of all the people that are positive by the test, how many are truly positive? So in this example here, all the people who are positive by the test is A plus B. Right? So positive predictive value is A over A plus B. Don't mix it up with A over A plus C. A over A plus C is sensitivity. right? Sometimes students mix up sensitivity and positive predictive value. Tell us slightly different things. So out of all the people who positive by the test, how many are truly positive? If I say a test has a positive predictive value of 85%, what it means is if I get 100 positive results, 85 out of those positive results have the disease. If I say the dimer has a positive predictive value of 60%, it means out of 100 positive D-dimer results, 60 out of 100 have the disease. If it's whatever you're looking at, if it's PE or DVT or whatever it is. Right? So what would be the positive predictive value here? A over A plus B. 6 over 6 plus 2, 8, 75%. So the higher the positive predictive value, the better the test at ruling in the condition. Again, what is considered high? It depends, generally more than 80%, but sometimes you want a positive predictive value that is even higher. Depends on what you're trying to accomplish. So guess what's negative predictive value? Negative predictive value then is what? Out of all the people who are negative by the test, how many are truly negative? So negative predictive value is D over C plus D. So if I tell you the negative predictive value is 90%, it means if we get 100 negative results, 90 out of those negative results truly do not have the disease. That's the meaning. Right? So that's the interpretation. Right? Negative predictive. The higher the negative predictive value, the better the test at ruling out the condition. Following me so far? Yeah? Didn't lose anybody too much? No? All right, good. Again, don't mix up negative predictive value with specificity, right? So specificity and sensitivity go down the table, whereas the predictive, because they're in relation to the disease, if you have it or not. But predictive values go across the table, they're in relation to the test results, all right? So what would be the negative predictive value here? Yeah, what would be the negative predictive value here? 31 over 35, most correct, whatever it is that will come to. Perfect. Now, specificity, right? Positive predictive value, negative predictive value, right? Right, so if you do a diagnostic study, then you could get prevalence from a diagnostic study. And that when you do a diagnostic study, prevalence is really what? What proportion of people have the disease? So how do you think you'll work out prevalence from a diagnostic study? Prevalence would be all the people who have the disease over everybody who was tested. So that would be what in this case? 10 over 43. 43? Yeah, 10 over 43 after everybody, right? It wouldn't be 6 over 43. Because we said 6 is the people who were true positives. It's not everybody with the disease. Everybody with the disease is A plus C. So prevalence from a diagnostic study is all this over the grand total, right? So that's how you can work out prevalence from a diagnostic study. Right? We just worked it out. 10 over the grand total, you add everybody up. So it's interesting because some tests, this table that we drew here, this one, the diagnostic study table, assumes, well, I suppose it's really one thing it's really assuming for both tests. To draw this table, it assumes that both tests were dichotomous. Dichotomous or binary, meaning there's only two possibilities. So they have the disease or they don't have the disease. So it's either the CTPA positive or negative. It's either the biopsy say cancer or no cancer. But in reality, sometimes when we do tests, the test isn't black and white. The test is a number. So if I tell you either a guy had PSA, prostate cancer by biopsy, yes or no, but we want to see how accurate PSA measures up against that. Then how you say if the PSA positive or negative? What do you do? How you know PSA positive or negative? If I ask you if the PSA abnormal or not, what you do? You're looking at the report. You're going to look at the range, exactly. And when you look at the range 4, if it's more than 4, you can say yeah, high. If it's less than 4, you can say yeah, normal. So if it's more than 4, you can say positive. If it's less than 4, you can say negative. Right? So the only way you could do that is to pick a cut point. Now, if the index test you're using, you're picking a cut point, what cut point you pick? How do we know what cut point to pick? How we actually know that is from diagnostic studies. There are actually interesting ways they could actually work it out. But what they do is they pick different cut points and look at the effect it has on the outcome, on the result. How we get a PSA of 4? Where that come from? Why not 6? Why not 10? Where normal value of PSA come from? I mean, derivation of reference ranges that use in labs as a whole separate thing in itself. But you always have to ask, if you're talking about cancer, how we know? Suppose I told you, I suppose today it was 4. Suppose I wake up tomorrow and I tell you, here are all the normal range now is 0 to 10. What effect that will have on you making a diagnosis of prostate cancer? So it has an effect. And this table illustrates that. If you raise the cut point, the specificity increases, but the sensitivity decreases. So assuming this number thing that you measure, and a higher number means you're more likely to have the disease. In the case of PSA, it is. The higher PSA is, the more likely to have cancer. I saw a guy the other day, he came to the office in a wheelchair, pain, look at the x-rays, they did x-rays because he couldn't walk, and then back pain and hip pain, couldn't walk, looking at the x-rays. I've seen sclerotic lesions all over the x-ray. I tell them even before we do the PSA, I say there's a chance this man probably have prostate cancer. Again, back pain, spinal pain, he can walk. PSA come back 141. You're thinking, yeah, this person have cancer, prostate cancer. But we probably don't need a value so high to diagnose cancer. But if we raise the value, if we really raise the value from 4 to 10, what happens? The specificity increases, but at the expense of sensitivity. So if you raise the cut point, and a higher cut point means you're more likely to have the disease, like the case of PSA, then raising the cut point increases the specificity of the test, but it decreases the sensitivity. So that means raising the cut point, increasing the chance that you could rule in the condition, but it is at the expense of sensitivity. The ability to rule out the condition would decrease. So what effect then you think would happen if we go to decrease the PSA? Suppose I get up today and I say, well, no, normal today for PSA today is 0 to 1. If I drop it to 1, what happened? Sensitivity would go up, but specificity would decrease. Right? So let's learn that. Raising the cut point for a disease, if a higher cut point means you're more likely to have the disease, increases specificity but decreases sensitivity. And vice versa in lowering the cut point. This illustrates it. If you pick a higher IM score, meant the person was more likely to have depression. So if a person is 55, you're more likely to have depression compared to 50. If you're 60, you're more likely to have depression compared to 50. So look at sensitivity and specificity. When I pick a cut point of 50, sensitivity and specificity was 70 and 79. But look at what happened when you raise the cut point to 55. The sensitivity went down and the specificity went up. If you pick a higher cut point of 60, the specificity went up to even higher, 94%. The sensitivity didn't really change too much. At the extremes, sometimes one tends to level off at the extremes. So this kind of illustrates that point. Higher cut point, if you pick a higher cut point. So in practice, how we know what cut point to pick? What they do is they do a table just like this. So they pick different cut points, 50, 55, 60, 65, 75. You could go the other way too. And for each cut point, you would have a diagnostic study table. Remember, when cut point change now, then the numbers in the table are going to change. You'll get a different pair of sensitivity, specificity values. So again, the ideal cut point is the one that gives you the highest sensitivity and specificity put together. So sometimes one of the ways they figure it out is they simply add the sensitivity to specificity. If we add it, what we get here, 149, right? If we add this here, we get what, 145. If we add this here, we get 144. So then the pair that was given it the biggest range was this one. So then they would say, let me use a cut point of 50. We'll get the best of both worlds. If your rule though was to rule in depression, I don't care about people who are depressed. I just want to make sure everyone who I diagnose with depression really have depression because I'm going to put them on antidepressants that can make them sick. Then you might say, well, I want to be sure a real person really have depression. I'm going to go with a cut point of 60 because that one produces the highest specificity. Right? So in practice, how they choose specificity and sensitivity for tests and the cutoffs they pick sometimes depends on what sensitivity, specificity values that the cut point actually produces. Right? So just keep that in mind. So the last pair measures that you should be able to work out from a diagnostic study is what we call likelihood ratios. If you do a test you know, you need to go standard doing a test. Let me just say you're doing I don't know, the dimers for PE, and it come back positive. It could be only two things. It's either A, true positive, or A, false positive. Similarly, if you do the dimers test and come back negative, is it the gold standard? You don't know. Ask yourself, it could be a true negative or false negative. What likelihood ratios do they take the two possibilities and consider them in one? So a likelihood ratio is the likelihood of the two possibilities for a given result. As I said just now, when I get a given result, it could either be a false result or a positive result, or true result. So we said this, a positive result could be true positives or false positives, same for a negative result. So the first one, positive likelihood ratio. What this does, it takes the true positive rate and divided by the false positive rate. Now, if you just look at this as a ratio, right? A ratio is just one thing divided by the other. As we'll see when we talk about odds ratios, it's just one thing divided by another. Relative risk in itself is a ratio because it's one thing divided by another. So in this case, if the true positive rate is on top and the false positive rate is below, a good test would have what? A high true positive rate and a low false positive rate. So you would expect this ratio to be a big number or a small number. A big number. How big is big? More than 10. That's just a convention to pick. Just like how we say the I squared 50. Again, it's just an arbitrary number that people pick. Of course, the higher the number, the better. So if I tell you the positive likelihood ratio was 50, then that is even better. If I tell you the positive likelihood ratio for a test is 50, what that means is when I do the test and I get a positive result, the chance that that positive result represents true positives is 50 times more than the chance that that positive result represents a false positive. That's really what it means. So, but more than 10 they say is good. But if you notice, the true positive rate we said just now is, if you all remember, sensitivity. So the true positive rate we know is sensitivity, and the false positive rate, we don't work that out. The false positive rate, if we go back to this table, if we said here, there's the true positive rate, which is A over A plus C, which we know is sensitivity. The false positive rate would be what? B over B plus D. It was B over B plus D. 1 minus specificity, the opposite. That's right. So the true positive rate is sensitivity and the false positive rate is 1 minus specificity. So that's how we get this equation. So if you take sensitivity over 1 minus specificity, of course you have to put it in fractions, right? So again, when you work in the pseudo term, then 90% is 90, right? 90% is 0.9. 100% is not 100, right, people? 100% is 1. Correct? So when you're doing the calculations, if you go with the percentage, stick to percentages. If you want to go with fractions, stick to fractions. So let me just say, I tell you, the sensitivity was 90% and the specificity was also 90%. Then it would be 90 over 100 minus 90, 90 over 10, 9. But you can't say 100% minus 0.9. Well, or 100 minus 0.9, I should say. Then you'll get a wrong number. You understand the point I'm making? So don't mix up percentages and values, right? So, and a negative likelihood ratio, again, similarly. You get a negative result, two possibilities. This makes a ratio of the false negative rate and the true negative rate. But no, the true negative rate is the denominator. So then if this test is really good, you want it to have more true negatives than false negatives. So then you'll expect this ratio to be small. How small? Less than 0.1. So it's kind of like the converse of positive likelihood ratio. In other words, both is by a magnitude of 10. When I get a true positive result, when I get a positive result and the likelihood ratio for a positive result is 10, you're 10 times more likely a positive result represents a true positive. When I get a negative result for your patient and the negative likelihood ratio is 10, it means you're 10 times more likely that your negative result is a true negative as opposed to a false negative. It's just that here they switch it up. This time the true rate is below and the false rate is on top. So that's why the ratio is a small number. Good if it's less than 0.1. Right? So good as if it's less than 0.1. Now, the good thing about likelihood ratios is they're based on sensitivity and specificity, as we saw in the last two slides. Right? We work them out from sensitivity and specificity. Likelihood ratios, both negative and positive. So one of the benefits of them is because they're based on a ratio, it doesn't vary in different populations or settings. What I would say is the predictive values vary based on the population you use, because predictive values vary with the prevalence of disease. If let me just say, and I'm making this up, if let me just say troponin levels has a positive predictive value of 80% in the emergency room for ACS, in a general practice setting with the amount of patients coming in with chest pain and ACS is much, much less. It's a much lower prevalence of ACS we would see in GP as opposed to in the emergency room. If we look at people even complaining with acute chest pain, the positive predictive value in GP for the same troponin test would be less. Similarly, if the negative predictive value for a test, that varies depending on the setting. The lower the prevalence, the better the negative predictive value. So let me just say we're looking at depression in general practice. Depression in general practice, 12% prevalence. If you look at the proportion of people going to emergency who have depression or meet criteria for depression, I'm not sure what that value is. I don't know, I'm not sure. Let me just pretend it's I don't know if it's higher or if it's lower. We could only wonder. Some people I'm sure have done the research and studies to see. But if you do a test with in a population that has a much lower prevalence of a condition, then that test, the negative predictive value is higher. So predictive values vary with prevalence. And it kind of makes sense because predictive values go across the table. And going across the table, if we change the prevalence of a condition, what we really change in is the ratio of these numbers of people to these numbers of people. Because we said prevalence is this over the grand total. So it kind of makes sense that prevalence will be affected by predictive values, right? So keep that in mind. Predictive values are affected by the prevalence of. So some tests tend to not perform well in certain settings, be it emergency or GP settings, simply based on the fact that the condition you're looking at is either more prevalent or less prevalent, right? So just keep that in mind. But sensitivity and specificity does not vary with prevalence of disease. Right? So keep that in mind. Sensitivity and specificity doesn't change with the prevalence of disease. Other things could affect sensitivity and specificity, as we'll see, but prevalence of the disease is not one of them. It could be used directly at the individual level, likelihood ratio. So if you're doing a test and it has a positive likelihood ratio of 100 and you get a positive result, you could tell the patient, well, 100 times kind of sure that this really means you have the disease. You know, you could tell the patient. So before we go into this thing called pretest probability, what is I want you all to do is let me work out an example, right? Let me work out the actual examples. I'll give you all an example to work out. Let me just say we do let me switch up. All right, let me see if I can edit this. Can I edit it? Double click. No. No, all right, okay, I probably can't edit it. Let me see if I can edit this one. These things sometimes could do weird things. Right, let me see. Now the computer decided what to stick on me. I want to freeze up on me. Hopefully it unstick. What's this? Windows, kind of stars. Close this, right? Let me see. All right, so I'll change it here. So let me just do over this data, right? So I'm just going to put some data here. So let me just say this. And this is 5. Let me just say this here is 55, and this here. What to do based on this information is work out the sensitivity, specificity, positive, negative likelihood ratios, positive, negative predictive values. Let me see if you could come up with it. Hopefully, I know most people write and they will copy down the equations. If you need me to go back to any of these slides, we could actually see. Just tell me and I'll go back to the slides. All right, so work that out. Let me work that out and see what values you'll get. All right, so the equations is something you know, right? Sensitivity is A over A plus C. Specificity is D over B plus D. Positive predictive value is A over A plus B. Negative predictive value is D over C plus D. That is really all you need to work out these values. Right, I've seen all the phones out, everybody typing away, right? The last people who, well, as I say, when I did this for EBM, for emergency med people last year, they complained, they say I make them buy calculators for the exam, right? So, and everyone will have the calculators ready to do the calculations, right? So, let me see.
Is it just those 4 parameters we calculated?
6 sensitivity, specificity, positive and negative predictive values, and positive and negative likelihood ratios. Right? So the six values we just spoke about.
Okay.
Yeah. I mean, to work out the likelihood ratios, you first have to work out sensitivity and specificity, right? So once you work those out first, to calculate those becomes a little bit easier. Easy thing. Seen some people finish. I've seen some people still busily typing away. Right? You guys online,
Yeah, we're done.
how y'all doing? Y'all think you have the answers?
Yeah.
All right, okay. So let's see. This is the point of the big reveal.
Yeah, we do okay.
A question.
Doing good.
The true positive rate is A over A plus C, which is the same as sensitivity. That's the true positive rate. Yeah. Yes? Correct? All right, so let me do the big reveal and let me show these answers. So what I'll do, I'll just come out of this presenter view and I will go to a calculator. So I could cheat, right? Right? I could cheat because I know how to calculate this thing. And you wouldn't have this in the people exam. right? So I think these are some of the calculators I put in the forum, so you could actually use them for the forum. So actually, this is a nice calculator that I use actually for evidence-based medicine stuff, because it actually, if you notice, has all the calculators for the main study types that we speak about. All right, so it makes working out all the things that we speak about for this course easy. So I just, which one I have to pick? I have to pick diagnostic. And then what I do, I just have to now, see, look, disease, no disease, A, B, C, D, this looks familiar. So what we have to do now is just put 80, and then 55, and then here I have to put 5, and then 65, right? Yeah, you don't have this for the exam, unfortunately, right? Unfortunately, you don't have this for the exam. Or the exam will be online, as you all see, it will be an online exam, but you don't have this for the exam, right? You will only have to stick to the browser screen that you have in front of you, so yeah. I know it might be enticing, but yeah. So you all ready? Get results?
Yep.
Play the answers here. Sensitivity, 94%.
Yes.
Specificity, 54%. Positive predictive value, 55%. NPV, 93%. Positive likelihood ratio, about 2. Negative likelihood ratio, about 0.1. Perfect.
Yeah.
Excellent. So it's good that they're not like crying and holding their head at this point in time. Some people are like, yes, Laura. Yes. Tell me what you use in calculating your positive likelihood ratio. Just tell me the numbers you use. Right? Right? So then you should have said sensitivity 0.94 over 1 minus 0.54. That's what you should have done, which is 0.94 over 0.46. Right? You wouldn't get this exact value, guys, because of rounding. Right? Because of rounding. Because if you use 94% instead of 0.941, you'll get slightly different. Because around, but you should get around the same thing, about 2 and negative 1.
Yeah.
So based on this, then, what you'll say about this test? It has high sensitivity. But low specificity. So it kind of good at ruling out the condition, but not so good at ruling in. How about the predictive values? The positive predictive value is 59%, but as the negative predictive value is 93%. So again, if the negative predictive value is high, it tells you the test kind of good at ruling out the condition. Positive likelihood ratio, 2. That good? We said it should be more than 10. But 2, not all that. Negative likelihood ratio, 0.1. Kind of like just on the border. So if anything, if you get a result showing these results, it kind of tells you the test kind of good at ruling out the
disease.
Yeah? All right? Yeah. Now notice this. Notice for specificity, and all of them, notice confidence intervals calculated. Confidence intervals, remember the 2 things you'll have to interpret for the rest of your careers are confidence intervals and p-value. You all know how to interpret this. You all could do this. How we interpret the confidence interval for this. So we are talking about weighted mean difference. We are talking about relative risk. What's a confidence interval again, broadly? It's a range that has the real value. So what does mean 95% of the time? So what does mean is on your worst day, your sensitivity is going to be 87%. On your best day, it's going to be 97%. What do you all think? On a worst day, 87% good enough for you? If you said you want a sensitivity of at least 80%, then you're good to go. Right? Now, if specificity is 45% to 62%, at its best is 62%, you happy with that? No. At its worst is 45%, you happy with that? Anyhow you take it, exam is bad. So the interpretation of the confidence intervals for these diagnostic study measures is different. It's not the same interpretation as the confidence interval for relative risk. It's not the same interpretation as the confidence interval for a mean difference. So anytime you see a confidence interval, the first thing you have to ask yourself, what is this a confidence interval for? Right? And that's the interpretation. Again, it's the same concept as we saw with the interpretations today. You look at the extremes and ask yourself if the extremes are acceptable for you. In the case of these, what is helpful to do is look at the lower limit. Because the lower limit telling you how much it is at its worst. If at its worst, it's still acceptable for you, then you can say, yeah, we're good to go. But if that is worse, it's bad, then you'll say, well, nah, that's not good enough. Now, again, I mentioned it when we spoke about the RCTs, what determines the width of the confidence intervals. You all were good at describing them in your appraisals. You say this confidence interval narrow, or gosh, this confidence interval broad, boy. What determines the width of confidence intervals is the number of people in the study. So if we change these numbers by a factor of 10, I'm just going to add a 0 to everything, would that change the measures? Confidence intervals should change, but would it change all these values we get here? Sensitivity, specificity? No, it shouldn't. Because the proportions, right? We increase everything by a factor 10, so it should change. So if I hit get results now, watch it good, right? Watch it good. Watch to see if these numbers changing and watch to see if these numbers changing. So I go and hit get results. Watch it good. What you notice? The confidence interval get really narrow. So how narrow it get? 92 to 95%, just not those 80 something to 97%. Right? So that just emphasizes the point that a more precise confidence interval is usually obtained by simply having enough people in a study. Right? Some people come to me in the past and they say they're doing a diagnostic study and they want to know how much people is enough. I say, well, what is you looking at? Last time someone came to me, they would say they were looking at, I think it was, I can't remember if it was an emergency medicine DM candidate or somebody. They were looking at to see if some factor could predict today mortality in patients presenting with sepsis. I think that's what they looked at. So I asked them, well, how common you think mortality going to be in your study of people? How much people on average presenting in sepsis eventually die at 30 days? They said, Doc, well, it's probably about 5%. I say, well, okay, and how much people are thinking about looking at, about getting? I say, well, I want to get so far, get like about 150, you know, and they want to know what is that, you know. So sometimes what happens if we do diagnostic studies, we just say we're looking at 100 people and the prevalence of the condition is 5%. Let me just say get a result like this, 4, 1. And let me just say, so 5 people had the disease, 5 people had the condition. And let me just say, how much we remain at now? 90. Let me just say now here, this was B is what the false positive. Let me just say that. Say this was 80. You do your study, these are the results you get, you calculate your values. What you notice about the sensitivity? 0.8. Look at the range. It's wide. So the problem with doing studies sometimes if it's really too small is the precision of your estimates tend to be really, really poor. So then some people say, well, so that then tell me then how much is enough? So as of course beyond the scope, I'm gonna mention sample size. I wouldn't talk about it intentionally with you. It's beyond the scope at your level, but they are calculators that you use. Right?
Dr.
Yes.
Is this similar to power, the number of people needed for the study? Is it similar to power?
Say that again. Is it similar to?
To power, the power of a study.
Yes. So power has to do with the a study with more people have more power is a more powerful study. Power usually has to do with determining if a difference exists in reality, if your study could prove that. So let me just say cinnamon really does lower sugar level, and you do a study, you would hope that the conclusion of your study would be cinnamon lowers diabetes sugar levels, because in reality that's the true effect. So the probability that your study could confirm that that difference exists is really what power is. So by definition, power standard set is 30%. We want generally that a study is at least powered at 80%. So usually power, we'll mention it next week. Power is related also to sample size. So the more people in a study, the more powerful the study is. A study that isn't as powerful tends to be studies with low numbers in it. So it is related to answer your question, right?
Okay.
The numbers of people, more powerful study. Again, how much is enough? It have sample size calculators that tell us how much is enough, right? You don't have to be concerned with exactly how we figure it. Any questions at this point? Any questions? Anything? No?
If I just have to give an answer, just ask me what is the sensitivity of the test. I could just say 0.3.
That's right.
I don't have to say 80%.
No. Well, right. You could say 0.8 to 80%.
Okay.
Either one is correct. But what I would say is you have to go a step further and tell me the confidence in this. You seem dumbfounded by that. You seem like...
No, but if we look up Draw a table. And
Right.
just figure it out.
So let me say we draw this table. There's the table we draw and there's the values we get. We draw it. The sensitivity was 80%, but it's not good enough to just tell me it was 80% alone.
What if you give us the confidence interval?
You need to give me the confidence interval. Because when I mean you all work it out, I don't mean you all have to work out the confidence interval. I mean an interpreter in the search, right? Don't be up and run away from the class at this point, please. Right? So no, you don't have to work it out. Calculators work it out for you. But I mean, like if you're reading a paper, or if someone tell you, well, and we did a study and the sensitivity was 80%, you should ask how much the confidence interval for that 80%
But if
was.
the lower limit was in this case 57%, then the test is not there.
Exactly, the test is not all that great. So the reason I tell you you should ask for the confidence interval because it affects the way you interpret, right? Because sometimes small studies tend to have wide confidence intervals. So in this case, really, this is too wide. 96% is great. I'll take that any day. But I mean, 37% is really poor, right? It's really, really poor. And again, you could bet if we just add a 0, it would change the actual values, but what it would change is the all of a sudden, if we increased everything by size 10, then all of a sudden, look at this. A little bit better, 67 to 88%. Right? So I just had to digress a little bit to emphasize the point of what a confidence interval means for sensitivity and specificity, how we interpret it, and the fact that more people in a study means that your sample, bigger sample size means narrower or more precise confidence intervals. So going back to this now, and what it is, I would say, only a few, 1 or 2 little things to talk about again. What I would say is, what's this thing called pretest probability? What do the word suggest? Pretest probability. Before you do a test, what's the chance of the person having the condition? So how we could figure that out? How we could figure out what is the pretest probability? The pretest probability for disease is roughly the same thing as prevalence. So if I told you all, again using emergency medicine people, if I told you all 30% of the people that is present a casualty with acute chest pain turn out to have some cardiac problem, ACS, then from the time a person presents a casualty saying, doc, my chest pain it started a few hours ago, you know that person has a pretest probability of 30% of having ACS. Pretest probability is roughly the same as disease prevalence. Now, if I tell you the chance that a person having ACS is 30%, we already say, well, I can treat a person with 50% chance of having a heart attack. I want to be much more sure because the treatment threshold for ACS is 90% in your book. I need to be 90% sure before I treat that person. Then 30% is not good enough. I need to do more testing to change that. So how we use this in reality and practice is through this thing called a nomogram. And a nomogram actually relates pretest probabilities. Blurry if you could see it. I don't know if you like taking it off and make it a little bit clearer. Right? We'll put it on back after once we come out of this. This nomogram, Fagan was the guy who created it, but this nomogram says it makes a relationship between pretest probability, that's simply the chance that the person had the disease before you do a test on them, likelihood ratio, which we know how to work, and post-test probability. Post-test probability is what? After you apply a test, the chance that the person has the disease. So you would expect that after you apply a test, that the person has a high chance of having a disease if you want to rule in the condition. If your job was to rule out the condition, you would hope that after you apply a test, that the person would have a very low post-test probability. So how we use this in practice? We don't use it in practice in the sense that you wouldn't have to use Fagan's nomogram in clinical practice, but people use it to influence the guidelines and to write the diagnostic guidelines and algorithms we use in medicine and practice of medicine. I'll give you an example. Let me just say a person has a pretest probability or a pretest probability, let me just say, having a disease 25%. Right? And you come and apply a test which has more than 1 is positive likelihood ratio, right? More than 1. I'm going this way, less than 1 is negative likelihood ratio. You come and you apply a test that has a positive likelihood ratio of 10. Fagan's nomogram simply says you draw a line from the pretest probability 25% through 10, and you end up at 80%. So now you have gone from a person with a 25% chance of having a disease to 80% chance of having a disease. So then you must say, well, if after I apply this test, then yes, this person really have the disease. After I apply this test with a positive likelihood ratio of 10, then it works out. Suppose I told you though that the test has a positive likelihood ratio of 2. And what we would do, I'm going to come out to present a view, a bit bigger, is what we do is then we have to draw the line now through 25 through 2. And where we'll end up? 50%. So when you apply a test now with a positive likelihood ratio of 2, the post-test probability is 50%. They hardly make a difference in terms of the chance of the person having a disease. If the positive likelihood ratio now was 50, then what we do? We have to pull this line through 50, and where we end up, we almost 95% sure now the person has the disease. So you see, it makes sense because just when we said that the positive likelihood ratio is more than 10, it's good at ruling in a condition. If I told you the negative likelihood ratio was minus 0.5, now good or bad? No, all that great. We want the negative likelihood ratio to be less than 0.1. So if you apply the same test now and it has a negative likelihood ratio of minus 0.5, you draw your line from here, and after that, you end up here. So you apply a test with a negative likelihood ratio of 0.5, and you have gone from 25% to 10%. You decrease the chance that the person have the disease to a certain extent. 10% to me is still a high chance the person could have the disease, depending on what you're looking at. If I told you the negative likelihood ratio was 0.05, is that less than 0.1? Yeah. That's really good. So what we do now is we draw a line through 0.05. So now we have gone to almost a 1% probability the person have. So this whole nomogram just emphasizes the point I told you all before. A positive likelihood ratio of more than 10 is good, and a negative likelihood ratio of less than 0.1 is good. But it also says you have to consider the person's pre-existing risk of disease. Let me just say, I tell you a patient come to you and you say chest pain, say GP. Describe the pain. What are you feeling like? Well, it kind of hurt, kind of grabbing, it kind of choking. It's good on my left arm sometimes. Sometimes it's good on my right arm. It's kind of burn me, sometimes it do burn me. Sometimes when I take a deep breath in, right? These patients we see, right? It's not clear-cut description. You might call it atypical pain. It's not clear-cut history of cardiac pain. If I ask you, what's this person's chance of having heart disease? Or what's the prevalence of the chance of this person having heart disease? Suppose that we just say the chance of this person has heart disease is 10%. Let me just say 10%. You say, well, we're not sure. You go and send you for a stress test. And if I tell you a stress test has a positive likelihood ratio of 10, what does that mean? It means if a person starts off with a pre-existing risk of having a condition, let me just say is 10%, and you come now and you do your stress test, and your stress test is positive, 10 through 10, it means now the chance that the person have the disease is 60%. Did it help? Kinda. You're still ain't too sure after doing the stress test, even if it's positive, that the chance that this person have heart disease is really high. Because the initial risk was low. The person say, yeah, doc, patient squeeze and grab and go up my jaw. And you say, well, I'm thinking this person have a high chance that they can have coronary artery disease. I'm 50% sure this person probably having heart disease. Now we're starting off with a pretest probability of 50%. If you apply the same stress test, which has a positive likelihood ratio of 10, now all of a sudden, the person's post-test probability is 95%. That is why certain tests work better depending on the patient's initial risk. That is why we could say, if you're thinking about PE, the algorithm start off with, say what, do what? Well score? Well score tells you if the person's chance of having the condition is high or low. So if you want to apply a test that could rule out disease, you want that the person starting off with a low risk of disease to begin with. So if the person have low risk factors for PE and the D-dimers is negative, you can tell the person here, well, go home. If the person though had high risk factors for a DVT and the D-dimers came back negative, what are you going to do? You might still probably want to send the person for the doctor to further testing because the pre-existing baseline risk to begin with was probably high. So if you apply a test with a low negative likelihood ratio, it's still probably not good at ruling out the disease. And it's based on this thinking is how we write or people write diagnostic algorithms in medicine for us to use. Person come in, this is what they had. The low risk, the high risk, if the high risk do this, if the low risk do that. Right? So some examples. Which one of these here good? These are typical history of cardiac chest pain. Positive likelihood ratio 115. Are good or bad? That's great. That means when the person said, doc, it feel like somebody rest 10 concrete block on my chest. The pain was going up to my jaw. You're 100 times more sure already that that person already having cardiac pain. We said a stress test is about 10. Just cutting it. Not all that great, just cutting it. How about this? These are likelihood ratios for hypothyroidism. Which one's good, which one's bad? This is specifically for Graves' disease. Positive likelihood ratio, which one's good? First, right. So what I mean, if a person have these signs, they almost likely, yes, they already have Graves' disease. How about the negative likelihood ratios? Which one's good? The last one, enlarged thyroid. So what that mean? If a person does not have a goiter, then they could fairly be confident they don't have Graves' disease. Understand? Because remember, negative likelihood ratios is about ruling out. Positive likelihood ratios is about ruling in. So that's how we use it. That's the interpretation. Right? And when we do the appraisals, these are the kind of questions that are usually asked. What else I would do? I wouldn't go into this. It's on the lecture. I wouldn't go into it. Natural frequencies is really what we have been talking about all the time. Natural frequencies simply refer to the actual numbers as seen here. So these values are what we call natural frequencies, actual numbers of patients. That's really all it is. I wouldn't go into the natural frequencies bit of this. Not really too important. The main thing I want you to grasp is this table, the 6 measures, how we interpret it. That's the main thing I expect. I want you to grasp. Questions? Questions? Questions about anything we spoke about? And there's a lot to go through, digest. Go back to use the examples, check out the forums, right? I have lots of these calculations in the forums. For the forums, you could use the diagnostic calculator. I think I have listed so you can test it out to see, right? People tag on the diagnostic study forums. It have a few readings that I put for you all to look at. You know, always put up one or two little extra things just to supplement what we talk about in class. Look at that area under the curve. That is one of the ones that you'll see, and there's reported a lot in the medical literature. So we look at that in terms of what it means. So just read that reading. And I'll stop here and see if you all have any questions.
One more thing, just
yes.
What is that positive likelihood ratios of good at ruling in disease?
Right. So I'll say it all over again to summarize. So sensitivity, if it's high, is good at ruling out disease. Specificity, if it's high, is good at ruling in disease. Positive predictive value, if it's high, is good at ruling in disease. Negative predictive value, if it's high, is good at ruling out disease. Positive likelihood ratio, if it's more than 10, is good at ruling in disease. Negative likelihood ratio, if it's less than 0.1, is good at ruling out disease. That's the bottom line. If I manage to confuse you for the last hour of speaking, that's the bottom line and take away from this stuff. Anything else? If no questions, note the exam date. It changed, right? It would have been on Friday if you noted the exam date will be the 21st. That's because we will be doing the exam online. So it's online school later. So that is when the exam will be. It will be in the library in the lab, right? And it will be an MCQ exam, as I mentioned, right? So it will be on the 21st of November. I suppose I would have done it on the Friday, but the Friday the lab is booked. So just letting you all know so you don't forget. I know with your scheduling, you kind of like probably clear Fridays for the next couple of weeks. So just keep in mind the exam will be on the 21st. And I suppose you ladies from Tobago, we'll see you all because you all have to come to the lab here on the 21st.
Yeah.
Yeah, so you'll book your tickets, make sure you get from before, right? I'll finally get to meet you all and faces to the names. Yes. You need the student ID, not so much to write the exam, but you need the student ID to be allowed in the library. If any issues or problems with the student ID, the library shouldn't get any trouble. I will be around. I could always tell them, yes, I verify you are my student, and they will kick out. But you work with the IDs eventually when you have them. Right? So if nothing, that is it.
Thank you.
That seems like it. So we signing off. Take care. See you all next.
Bye.
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 Bye.